Okay, it's my pleasure to introduce today's speakers, Dr. Bryan Sisk and Dr. Anna Kerr. Dr. Sisk is an assistant professor in pediatric hematology and oncology at Washington University School of Medicine. He completed his MD at the Cleveland Clinic and had additional clinical training at St. Louis Children's Hospital and Washington University. His research is focused on communication functions in pediatric oncology, and he's especially interested in the social and ethical issues related to the child-parent-clinician relationship when children have serious illness. And Dr. Kerr is an assistant professor in the Department of Primary Care at Ohio University, and she completed her PhD in communication at the University of Kentucky. And her primary research focus is on health communication with an emphasis on interpersonal and family communication. And the title of their seminar today, their presentation today, is Barriers to Expert Care for Patients with Vascular Anomalies. With that, I'll turn the seminar over to you two. Thank you.
Excellent. Well, thank you so much. We're really excited to be presenting on this topic today. And I know a lot of what we talk about on these presentations are usually basic science, translational science. I'm really excited to take this to the other end of how do we get those exciting discoveries to patients. So we have no disclosures or conflicts to talk about. And there's really three big goals of the talk today. One is to establish the importance of understanding these challenges. Number two is to tell you about some of our research that started to map out what are the factors affecting the ability of these families to access care. And then three is to tell you about and engage you in discussion about what should be some priorities for future research in care delivery for vascular anomalies. And before we get into what we did and what we found, I want to really frame this from the perspective of patients that we've seen, because I think that's why we all do the work we do, is because of the patients we see. Or the patients we're hoping our work will influence. And the first patient is a 37-year-old woman that I met in clinic last year. She had a facial and an oral lymphatic malformation. By the time I saw her, she'd had over 70 procedures, including sclerotherapies and surgeries, but hadn't had care for the last decade. If you look at the picture here, you can see there's oozing, there's lymphatic involvement of the tongue, chronic bleeding, which she described as feeling like I have an all the time open sore in my mouth. It was influencing her family life, influencing her mood. She was chronically depressed. And she told me that she was really worried she was becoming addicted to alcohol because that was helping her to cope with that constant pain. And the last time she saw a doctor, she said, she's thinking about that. She said, all my doctors told me they couldn't help me. So essentially she stopped looking. Once she got to our clinic, we trialed sirolimus. And after 2 months, her oral bleeding had totally stopped. Her pain had improved. She said that she didn't drink alcohol anymore. Her mood was better, and her family life was better. So all of these benefits that had kind of been sitting on the shelf to offer her for at least the last 5 or 6 years. And if she hadn't by chance bumped into our clinic, it could have been another decade or longer before she actually got some benefit. And then the second patient is a 5-year-old girl that I met in clinic who had a large lymphatic malformation on her left medial thigh. She'd never been seen by vascular anomaly specialists until she got to our clinic, but she had gone through 2 very large aggressive excisions. And the way that the family described it is they said that they were in a rural area and they saw their community surgeon who said, I'm not sure what this is, but let's take it out. And they took it out and then it grew back. And he said, I'm still not sure exactly what this is. Let's take it out again. After that second excision, she developed a really big, thick scar and had trouble healing. And so they tried scar revision, but then the graft failed, so they had to close it up again. And now she has this thick, painful scar. And when she presented with us, her big concern was that it was limiting mobility and she was having this chronic pain from the repercussions of the surgeries itself. If this was a patient that came into our clinics these days, that kind of aggressive surgery is not the standard of what we would approach. We would often approach with monitoring or some mix of sclerotherapy, possible surgery, and then medical therapy that was really driven by the goals of that family. And this is a patient that if they'd gotten to people with a little more expertise or experience with vascular anomalies, might not be having this long-term symptom. And these are just 2 patients. But, as I started seeing more and more of these patients, themes started to arise from these conversations. They're hard to find doctors who have heard of these disorders. I'd had a number of families that the parents started crying because I had heard of their child's rare disorder. Not that even that I was offering treatment, just the fact that they found a doctor who knew what it was really meaningful to them. That some families talked about being dismissed or not feeling like their insights were being appreciated, or challenges with getting a diagnosis that's accurate or having diagnoses change over time. As we looked at getting inappropriate treatments or not having access to treatments, and then the troubles with finding high quality information. And so these were all things that Dr. Kerr knew about, and I had started learning more and more from these clinical encounters. And then the reason this really stuck out to me is that we are learning so much. As you learn every month on these conferences, we're mapping out pathways. We've got over 6 or 7 years of solid evidence that sirolimus helps a lot of these patients. We just got FDA approval for a targeted inhibitor this April. So the rate of increasing knowledge and the rate at which we're able to translate that knowledge to help patients is very, very quickly increasing in pace, which makes it even more imperative to get patients into experts who know how to benefit them with these improvements. And so what we were thinking is the ideal when you look at having a medical problem and getting to expert care is you have a symptom, you go to the doctor, they tell you what it is, they treat it. That's the ideal. But this is what we were seeing from more and more of these patients. It's a circuitous route that has a lot of influences, and the arrow doesn't always get to the end point. Sometimes there's a block right here and you just stay in this swirl. But anecdotes are important to trigger interest in research areas, but anecdotes are not sufficient evidence. And if it's not described in the literature, then it doesn't exist in the eyes of funders and evidence-based folks. So we thought we really need to go to the literature and see what's been done on this. And we thought initially about maybe doing a systematic review. And then when we looked around, we found that there were only 5 articles on communication, and Dr. Kerr had written 4 of them. So we thought maybe we should actually write a commentary instead. And so this was the commentary we wrote, saying, this is a really important issue that we need to start digging into. And the European group with Ovama has done some really good work starting to map out quality of life. But other than that, there really was virtually nothing about how these families are accessing care, how the care is delivered, or what the burden is of the disease. And to give a little bit of context, around this time, I had done a systematic search for communication studies in pediatric cancer, only over 3 years, and there were 89 studies. So 3 years in pediatric cancer, 89 studies. All time ever, vascular anomalies, 5 studies. So a big open area that needed some searching. And when Anna and I were looking at it, we thought if our goal is to improve access to care, there's a couple things we need to do. One is we need to understand what are the challenges. We need to qualitatively understand what are the different types of things that are getting in the way for these families. And then we need to be able to quantify it in a way that helps us to know how significant are the problems. And there's 2 reasons for this. One is, one is because we need to know what we should be targeting if we try to develop interventions to improve access or overcome these barriers. And then number 2 is because if you don't document it, like we said, it doesn't exist. You can't go to a funding agency and say, we have a lot of problems we need to fix if you don't have evidence that the problems exist. So our first approach to this question was to really map out in a qualitative and quantitative way, what are the issues that these families are experiencing? We were really fortunate that we had some patient advocacy groups, including LGDA, I see Mike Kelly on here, and the Orphan Disease Center, that were interested in helping us to answer this question. And so our first study, I'll just focus today with Dr. Kerr on AIM-1, which is to say, how can we get parent and patient perspectives on what it's like to try to get care and to communicate with doctors. And so we did interviews with 34 parents and 25 adult patients, which is in the qualitative world is a good sample to get thematic saturation. And we'll talk a little bit about the second AIM a little bit later, but mostly we're going to focus on this first AIM. And here I'm going to hand off to Dr. Kerr to walk us through some of these results.
So what we're summarizing here are those factors we found that were affecting the pathways to care, and not just the ability to access that expert care, but to maintain care and have continuity of care to get to those better health outcomes. And so we'll summarize these 6 today. As you can see, this is from a recent publication in Orphanet, so we can add the link there. It's open access, but we'll just give a brief overview today of how we see these factors playing out for both parents and patients, and then how that's driving our research agenda moving forward. But we found 6 factors that the initial symptoms prompted this journey to seeking care. And these 6 factors influenced both at the accessing care and maintaining care points. So the first thing that we found were individual characteristics, and this included both clinician and parent characteristics. So clinician characteristics were things like knowledge, investment, effort, helpfulness. Things like facilitating referrals and escalating care were really important, but also providing validation of the parents and patients' concerns and offering support in many ways. And so they were often encountering these physicians who lacked knowledge, and they really found it beneficial if a physician was willing to say, I don't know about this, but I'm willing to help you find it. And unfortunately, as you can see here, they encountered many physicians who were unwilling to provide referrals or to help them find second opinions. So consequently, parents were burdened with educating clinicians, coordinating care, finding experts. And that's why parental advocacy really came through as an important factor. And it was really out of that desperation, that drive, when they felt like the clinicians they were finding lacked sufficient concern, knowledge when treatments were failing, or they just didn't feel like they had somebody who knew what to do. So some of the clinical characteristics they pointed to were either the role of an early and accurate diagnosis or how their child's clinical presentation affected the route to care. So the early and accurate diagnosis obviously helped them find information about their child's condition and help them identify expert physicians. But as we know, many families went months or years with an inaccurate or incomplete diagnosis. And so this really underscores that urgency of the accuracy and timing of a diagnosis. And then the physical manifestations on the skin or that were observed in prenatal screenings often led to early evaluation, but it often didn't lead to early diagnosis. And in fact, we saw over and over again that people were getting unnecessary and repeated tests and interventions that ended up not being helpful. And many of them really regretted it after the fact. All right, so scientific progress came up from many of the parents, and this was the idea that there's a lack of evidence-based knowledge about their child's condition, which meant that they just couldn't figure out, they couldn't find information. They also couldn't figure out what treatments would work, and they didn't know how their child's condition was going to progress. And so it was this big uncertainty of like, what does the future look like? What are we going to be able to do? They often felt that there was a lack of interest from scientists and other companies researching rare diseases to put some effort into this. And so as you can see here, they often felt very hopeless that this wasn't something that was a priority in the medical community. So several folks did talk about that when research studies and trials were available, it really helped them get a pathway to information. But there was this interesting idea that sometimes they felt obligated to participate in studies, like this parent who described feeling like a guinea pig. And so they found research and clinical trials to be both beneficial, but also burdensome when you're in a rare disease community. Yeah, social support. So the role of social media and patient advocacy groups really came up in almost every single interview. They found patient advocacy groups to be one of the #1 most reliable sources for information that could guide them, like what questions should I ask, what physician should I be seeing? And then the social support groups, they found people who would give them advice on social media, but also would be able to reassure them as they're kind of navigating the emotional uncertainty of going through this. But they found both of these sources to be some of the most credible places for actual health-related information. All right. So this was something that somewhat surprised us, but it made total sense, was this idea of the role of privilege and luck. We heard countless participants say they acknowledged that they felt lucky they had the financial security that allowed them to travel to these distant medical centers, to take time off of work, to be able to find sitters or other resources. Some of them had previous medical training, whether they were a nurse or they worked in a lab where they could access PubMed articles that are typically behind a paywall. And so many people benefited from some of these privileges that they had. But even with privileges, there were some people who just attributed their child or their own care to luck, whether they lived close to a multidisciplinary center or they had these chance encounters with a physician who happened to see a patient during residency or happened to hear grand rounds on something, and it triggered them helping to investigate it, even if that person wasn't their own patient full time. And so these chance encounters, the more we can get that knowledge into more people, the more we can create this network of care where those chance encounters are happening more and more often. All right, and then finally, the healthcare system came up. Almost every single person referred to the significant role of factors like access to multidisciplinary teams, care coordination between specialists and local providers, navigating insurance, and then finding access to treatment and services, especially locally. Many folks found that they would leave the specialty care and go back home and not have someone who's able to help them maintain the treatment regimen that they're having to do, or to find compression garments or whatever it might be. And so parents, again, found it overwhelming to make sense of this complex and often fragmented system of care, not really sure how it worked, and really feeling like there was nobody to help champion them through navigating it. And I'll toss it back over to Dr. Sisk.
Yeah, and as we're talking about the healthcare system, I wanted to bring in another study I'm working on with Sally Cohen-Cutler out at Children's LA. That was another survey study to look at what are the resources that are available for these families across the country. What we recognize is that despite our best efforts, it wasn't really clear around the country who is able to provide this care, especially people outside of pediatrics. And so what we aimed to do was reach out to clinicians to understand who is caring for vascular anomalies at their center, and do they have a multidisciplinary team, and what resources do they have available for that team. I'm going to talk mainly today just about where these teams are, and the rest of this stuff we're going to be writing up in a manuscript soon, and invite us back. So what we found through the Children's Hospital database was 200 children's hospitals across the country. And then we decided to approach it as doing everything we can to figure out externally, from looking up the websites, calling the hospital phone trees, tapping into contacts we had to see where can we find people in each of these hospitals that would say, yes, we have this person who takes care of vascular anomalies. And what we found from that is 145 of these centers had somebody that would identify as, I take care of these patients. And then we sent surveys to all of them. And then we had 94 responses. And I just want to focus on one point though here. Here's a heat map across the country of where all of the children's hospitals are from the Children's Hospital database. And it's a heat map. So each of these points represents a place where there's at least one hospital, and the colors represent the number of hospitals there. So New York obviously is huge, has 20 hospitals. St. Louis, I have to reference because I'm there, has 3. LA has 9, whereas Wyoming has 1 in the state. So this is the picture to take into your mind for how many children's hospitals there are. These are the institutions where it actually ended up being 142, where we were able to find somebody who said they take care of vascular anomalies. It's possible that these other hospitals have someone, but if you think of it from the perspective of families, if we as clinicians are unable to find doctors there, how are families able to? And then this is the slide that's very interesting, is where are their sites, their centers that say they have multidisciplinary teams to take care of vascular anomalies. And it shrinks down quite a bit to 83. And it's unclear that every site that says they have a multidisciplinary team, how exactly they function, or if all of us would consider it, but take it for granted that there's 83. There's huge swaths of places where patients are going to be unable to find a multidisciplinary group that can care for them in their state even. And that's important. When you look at the Midwest here, I'm starting to think of this as kind of the frontier of kind of this vascular anomalies healthcare desert until you get to the Southwest and the West Coast. And it reinforces a lot of what we're hearing from families. And then I wanted to pull in a little bit of research that was published by Ianella and her colleagues. This was another survey looking at adult patients to try to understand their experiences with care delivery. And of adults who were able to see a pediatric provider, 97% said they didn't have any plans to transition to an adult provider. But most importantly, patients that were not able to see a pediatric provider anymore, 34% of the people that responded to that survey said they stopped looking for doctors. 45% said they didn't have any consistent care for the vascular anomalies, and 60% perceived that the doctors they were seeing didn't have any interest or training in their disorder. And we are doing a survey right now, and this was just one response that really jumped out that I thought emphasized this point of the challenges adults are facing. And so this is a 40-year-old man with PIK3CA related overgrowth spectrum, who in the free response section of the survey said, "I'm just adrift on my own. I've largely given up seeing doctors for anything actually related to my condition unless it's absolutely necessary. Otherwise, I only go for acute things that seem like normal people problems that can be treated in normal people ways. As I've met more and more patients through this research and through advocacy groups, I think this is much more common in adults than we recognize. That there's a lot of adults that just stop trying to find care that could really benefit, especially given the advances we're having, month by month." And to summarize everything, why I think this really matters is, if I was a mad scientist and I said, I'm going to create a recipe that's going to maximize the chances of disparities, I would say something like, we should make it so that you have to have an insanely high level of advocacy for yourself or for your child to get care. You have to have financial resources, insurance, money, ability, job security, ability to leave your state, leave your half of the country to get expert care. You have to have luck where you by chance bounce into the right person that's heard of this, and you usually have to be a kid. That's a big recipe for disparity of patients out there that we don't know about, that haven't been able to get diagnosed and that aren't receiving care. So one of the things we're thinking about is, how do we start to get a better sense of who's not able to get care, so we can figure out what those leverage points are to modify and try and improve this. But I don't want to end with everything sucks and we're powerless, because we all recognize there's challenges in the healthcare system. We all recognize also that we can have a stake in improving the experiences for these families. And so another paper that that's under review right now is looking at advice from parents and adult patients. And I want to highlight some pieces of advice that they had for clinicians they're encountering. And first was really building that relationship with them. Showing commitment came over more and more from these patients. So a lot of families feel like they've been, especially families that have challenges, feel like they've been set aside by doctors who didn't feel that they could provide the care. And so even a doctor that doesn't have a treatment they can offer, to say, I am really committed to telling you what's new in the research world, telling you how I have context, how I'm staying up to date on this. Even that commitment without any deliverable gave people hope and helped them to feel like they were in the right hands. And then things obviously like being caring, being concerning, but also empowering. Parents often don't need a huge nudge to advocate for their child, but it helps them to get support and justification that you're really doing a great job for your child. And we know this is hard because of all the things that are going on in our system. When exchanging information, a lot of participants talked about how complicated this information is, how hard it is to find reliable information online and outside of clinic visits, and then how it helps when doctors and clinicians can use things other than just words. If it's a complicated process, have some type of a picture, have a multimedia, make it really easy and open for them to ask questions. But often, I find myself trying to explain things with my hands, and it's like, that's probably not helping them. Maybe we need something that can make it, get it verbal and visual learning. Another point that came up with from a lot of families is kind of this hidden emotional burden that they carry that often goes unrecognized. And it's not that families expect clinicians to be able to address or fix their emotional difficulties, but more so that by acknowledging this is hard for a lot of families going through this, it helps to validate them, to make them understand they're not alone in this, and also just shows that that clinician understands more of what they're going through and isn't downplaying their symptoms. And then uncertainty. was a huge aspect in all rare diseases, and especially for our patients. There's uncertainty pervading every aspect of care and communication. There's the uncertainty of, what do I have if I can't find a diagnosis? Is my diagnosis accurate? Is this diagnosis going to change names in a couple of years? When a treatment is offered, how do I pick which treatment is best if there's not a lot of data or information out there? Do I know if I can trust my medical team that's taking care of me? How do I choose if I stay in-state or out-state? And then a lot of questions about the future that we just don't have data on. What's going to happen? Am I going to be able to get pregnant? What's going to happen with my fertility? What's going to happen if I get pregnant to my malformation? And then a lot of concerns about what's going to happen. I'm 20, I'm 30. What's going to happen when I'm 60? I don't see patients like me. How do I know? Am I going to be in a wheelchair? Am I going to be able to function? So there's a lot of uncertainty that we can't fix, but the ways that we can help with that uncertainty are, again, committing to staying as up to date as we can on the field and giving them that information, showing that we're working as a team and that we're acknowledging our limitations. Families really liked it when we can tell them that we know other people in this field, we know people who are leading this field. We are going to give them the best evidence that we know of. And if there's anything we don't know of, we're going to be happy to reach out to other folks. We're going to be happy to offer second opinions. Acknowledging limitations goes a long way to building trust that you're the right doctor to take care of this patient. And that's the bulk of the data we're going to talk about today. We have a couple other analyses underway on this qualitative data set. We're exploring what the role is of primary care clinicians from parents' perspectives. We're digging into emergency care, both in the interviews and in the surveys. A lot of these families talked about challenges when they go to emergency care, and some of them just said, I just don't anymore. Talking about, one of the things that's important in all of our clinical trials is the impact on quality of life of disease and treatment, and how are we improving patients' lives beyond just shrinking down a lesion. And part of the question that keeps arising is, when we say quality of life, what exactly do we mean? And so we're doing an analysis of the descriptions of the different burdens of the disease on these families' lives, so that we can understand better what might be the right thing to measure for changes after interventions or treatments. And then we've got a study that's looking at what communication is striving to achieve for these families, and how does that compare to other serious illnesses like pediatric cancer. And that's the aim one. I want to briefly talk about aim two with a plea. So this is our parent and adult patient survey, where we're using validated measures to really quantify some of the things that we learned from our qualitative interviews. This is a process called sequential explanatory design, where you learn stuff from qualitative interviews and you say, I really want to dig more into that. I'm going to dig into it with these validated scales, where you use one method to dig in and understand better another method. And so what we're doing right now is a survey that's using scales to assess caregiver burden, the burden of disease, communication, trust, quality of life, health, literacy, anxiety, depression. We have been open for accrual for a few months now. We're doing pretty well. We've got 153 adult patients. We're really pushing to try to get at least 120 to 150 parents and caregivers. If you see patients anywhere in the world with vascular anomalies, you will likely not require IRB approval to distribute our flyer. Generally, IRBs say, this is not human subjects research. If you're not enrolling, you're just giving out an informational flyer, and they click a button on that or use the QR code. It takes them straight to a website that we run that can allow them to sign up. It either doesn't require IRB approval, or sometimes they require a paragraph to explain why this is not human subjects research. If you are interested, and I've not been bothering you by email yet, please feel free to email me. And we would love to get you guys set up to hand out some flyers to patients with vascular anomalies. We're hoping to finish up our recruitment for this probably in the next 1, 2, 3 months, so that we can get this data ready and get some good preliminary data for some subsequent funding. And then I'll hand it back over to Dr. Kerr to talk about some other areas that we are interested in looking at, and then also open it up to brainstorming from the group of other topics that you think are important.
Yeah, so this touches on several of the things you've heard us talk about today, are these areas that we see that there are a lot of opportunities for future research, both for designing interventions, but also for getting more of that data published. So we have evidence that we need interventions in these areas. And so emergency care, again, came up over and over again. And how can we develop resources that can facilitate acute care, especially when you are far from a specialized medical center? What are those ideal roles, and what should primary care physicians know in terms of working with specialists or coordinating care for these patients? Information needs came up over and over again. How do we create a repository? How do we continue to build up-to-date information that also can get to families and isn't behind a paywall? And so how do we make sure we're really creating an abundance of accessible resources? We're really interested in looking at those disparities. What are the disparities when it comes to accessing expert care? Who is able to get genetic testing and who can't because of financial barriers or other systemic institutional barriers that might prevent this genetic testing from happening? Care transitions came up again so much, right? That this starts in pediatrics, and as you translate yourself to adult care, what does that look like both within the family unit and then also in the healthcare system? And then finally, we want to make sure that what we're doing can translate to other rare diseases. And so how do we make sure that the tools that we're building can be used with clinicians who are seeing multiple rare diseases in their practices and with researchers who are doing the same thing? So we can really make sure that we're creating something that is evidence-based and has a lot of utility to it. So those are the future directions that we see, but we will open it up for conversations and questions about where you all see this going. And of course, we want to thank everyone who's been involved in this.
Thank you so much. This was a great presentation, very thought-provoking and very different from what we've had so far in this seminar series. So thank you once again. This was really exciting. So I'll start the discussion. I'm curious, these patients that have received, they felt like they received unnecessary treatments, do they have a reluctance to participate in future trials?
It's a really great question. The truth of the matter is it hasn't come up that much because there haven't been that many clinical trials to offer. One, like for example, the adult patient, we wanted to offer the Novartis trial to her, but because of insurance issues, she couldn't get genetic testing, and so she wasn't eligible for the trial. For the patient that had the big resection, at this point, she's had so much surgical scarring, it wouldn't make her a good candidate. She probably wouldn't have easily measurable disease. So I think it's an important point that potentially just these prior treatment experiences could diminish their interest in being a guinea pig, as they said.
And I'll add to that, I think so much of it depends on their trust in the clinicians. Many were acceptably skeptical of a physician who's like, well, let's just go do this and let's just go do this, but didn't really have an innate understanding of what they were doing. Where once they make it to this expert care and people go, oh no, they never should have done this. Here's why, here's the approach we're going to take. And it feels very educated. There was a little bit more trust in the process of like, they know what they're doing. But when they never made it to that expert care, they just saw every clinician is wanting to offer some sort of quick solution. We'll cut, we'll do whatever. And they became a little bit reluctant to that. And those were often those adult patients who said, I just stopped going to the doctor anymore because it got so bad.
Michael, you want to ask your question?
Yes. Thanks for that presentation. I think one of the things for me, when I switched to taking care of patients with vascular anomalies from hematology or oncology, was the concept of patient directing or shared sort of decision making, because we often say, what's your goal? And I guess in cancer or blood disorders, there isn't that kind of conversation. And that's why I think also for many physicians, it is uncomfortable and very, loose and open. What's your goal? I think that's a very difficult part in terms of switching your mindset, your own care mindset, and just those comments. And then I'll just make one more comment, then I'll let you guys talk about that. But one thing that I would say that I know that people have really pushed for ASH to be very open-minded and having presentations about that. And I finally had an adult oncologist who had attended one of those ASH sessions and was very open-minded about, oh, I can learn about this and I will learn, but it took that first presentation to have that occur. So I just encourage people to keep pushing for that. But I was just curious about your comments about the electiveness of these things.
Mm-hmm. And I think that's such an important point. And in some of the previous research I had done too is being very understanding the outcomes are relative, right? When you say we can remove that or we can do an excision surgery, being very clear that you're not going to wake up with it gone. It might be debulking it. You might still need compression garments. And so like having that honest conversation of, they might think they're getting a miracle cure and they're going to wake up and you're going to do an excision surgery and there'll be no evidence of the condition left, right? And saying, or if you're okay wearing a compression garment, maybe surgery is going to be too invasive and it'll be too difficult. And so it's really having that honest conversation about, is the outcome of the surgery exactly what you're looking for? Because I think you do find patients who regret going through this because I think it's a miracle cure. And then there's more side effects, whether it's nerve damage or different things that can happen depending on where it's located on their body.
Yeah, and I think to emphasize what Michael was saying also about, it's a huge mind shift. And the same challenges we have with clinical trials is the same challenges we have as clinicians. It's a lot easier to know what success is when you have cancer, because either the cancer is gone or it's not. And in pediatric cancer especially, there's, at least on upfront therapy, it's usually, here is a treatment that has been proven to be the best. So there's not a lot of questions about, are there a lot of other treatments? There's not a lot of questions about, how do we know if this is successful? It shrinks and it goes away. If it doesn't, we'll give you different treatment. In this, it's a total mind shift of leveraging much more that shared decision-making mentality of, tell me what it would mean if this got better for you. Because if I give you a medicine that's going to potentially bump your lipids and give you mouth sores and depress your immune system, and your face gets a little smaller, but you don't feel any different and it's not influence your life, then that's not the right drug. So I completely agree. That's another really important and interesting area.
Mm-hmm. Yeah, thank you.
Joyce has a comment. She says, thank you for the great thought-provoking presentation. These talking points can be applied to many rare diseases and raise disease awareness and work closely with patient advocacy group is very important. Michael, do you mind putting your hand down on the, and if there are any other questions, please feel free to unmute yourself and ask. While people wait, or come up with their questions, I'll ask another question. One of your slides, you had the caregiver and patient advice for clinicians. And I was curious if there was caregiver or patient advice for patient advocacy groups and what we could be doing better to better serve the patient community, if they had any thoughts on that.
That's a great question. We didn't ask specifically about that. I think we could glean some ideas from what they've told us. I'll talk first about some of the things they mentioned about social media and kind of the real benefits, but also some of the downsides, and maybe protecting against those downsides could be one area. Parents, a lot of parents loved having the access to other people with shared experiences. At the same time, one thing is parents really preferred taking different roles. Some parents really liked to be involved and asking questions and responding. But there were a lot more parents that really felt they benefited from these social media groups and advocacy groups by being an observer and being kind of in the background and scrolling through past questions, but not wanting to actively contribute. And so recognizing that both active and passive engagement can be really important depending on the family's needs. The other thing potentially would be preparing families when they enter into these groups, that not everything's going to apply to their child. That was something a lot of them said they had to learn. And some people said they stopped going to the groups because they couldn't handle seeing patients with really bad outcomes. And it was hard for them to figure out, does this apply to my child or not? And then there are also others that had kids with more mild symptoms, and they almost felt guilty when they saw other families that had worse symptoms. So I think maybe something about preparing families for what they might experience, how they might interface with that to make sure it's useful for the most families would be one thought. Anna, what about you?
Yeah, I'll echo both of those. That's the first thing that came to mind. And then I think too, just visibility, right? Like, how do we make sure that your organization is advertised at the point of diagnosis and there's someone knows to say, hey, you might also consider going here. and it's on the clinics to do it as well, but sometimes it's on groups to think about like, how are people finding us and what are they typing in and what are the search terms? Because some people would just stumble across it. And other times someone said, you know, a nurse came up to me in the hallway and said that you might consider going to this. And I'm so grateful that they did. But yeah, the other thing I was going to say is those passive, to be continuing to put updates out, knowing there's a lot of passive interaction that's happening, even if people aren't commenting or engaging in things, that they really benefit from being able to just have this kind of trove of resources and experiences.
Thank you. Are there any other questions or comments? If not, please join me in thanking the presenters today. This was an excellent presentation and very a unique perspective and different, completely different information on vascular anomalies, which is extremely useful. Thank you once again, and we'll see you all next month for our next presentation by Frederick Kapp. And please, I put Bryan's email in the chat for the pamphlet, and then also links to the papers. So thank you everyone once again for joining, and we'll see you next month.
Thanks, everyone.
Thank you all.
Thank you.